right, Steve. So, welcome to the Voices Project. Uh,
Thank you.
no worries. I mean, this is actually pretty interesting. It's sort of like the first episode of a sixth season, and I think most of our listeners know that I don't actually know what the agenda of the rest of the season is going to be until I start it. And there's always a little bit of inspiration, like the sort of proverbial apple falling on the head, and it happened to be our conversation. And so I'm going to just keep this the most freewheeling, natural conversations like you and I have just been talking about. And I'm going to do it with a lot of the context. I'm just going to simply say, for those who've been waiting for the sixth season, it's good to be back. I'm not going to give you that usual preamble. Most of you all know me, but the industry, as we know it in terms of research, health, geopolitical outcomes, it's not exactly the same as it was, I think since the last 6 months. So, let's see how this discussion goes. So we've covered all sorts of topics. We've covered prison reform. We've covered HPV and inequity. You name it, in 5 seasons. I think we've covered more and then some. And this season, I'm going to just get started with Steve in a minute. I'm so happy to have Stephen Potts, and we're going to hear more about Stephen Potts. And I'm going to yeah, I'll probably be two ears, one mouth for a change for this one. But intersection, technology, ethics, methodologies. Oh boy. So for any students out there, this is going to be a masterclass. Why is it even more interesting to speak with Steve? I've known Steve now for more than 20 years and decades of expertise in market research. I have learned pretty much everything, cut my teeth with sort of the work he was doing. And more importantly, I think it's a unique vantage point on where our industry is going and the future of that. So, welcome, Steve.
Thank you. It's lovely to be here. It's lovely to be anywhere, but
Yeah,
it's
it's good
lovely to be
anywhere,
here.
right? I mean, I wish we kind of could do this face to face, and maybe at some point we will. But you were saying you had a pretty good week. You had a few interesting uh, meetings, I guess. So life has been all right.
Yeah, it's been a great week. For those of you who don't know me, my face is a little bit wonkier than it was 6 months ago. I've had a brain aneurysm, and I'm on my way back from that. So I was lucky enough to be invited to the Ephemera UK chapter meeting in London. It was a big deal for me because it was my first big trip up to London since all of this happened. Stayed overnight in a hotel, my first business trip since this happened. Imagine getting excited about business trips again, Rohit. So yeah, really nice week. Lovely catching up with so many good friends. We're very lucky to work in our industry. I think it's a great community. So lovely to see old friends, but also make some new ones as well.
Yeah, no, absolutely. I mean, I think, the way that we've sort of just been already sort of just getting right into things, let's sort of give you a proper introduction. So, 30 years, gosh, 30 years, healthcare market research, career milestones and global perspectives that, goes on. And, I think how long is a, piece of string can go. You worked across pharma, medical devices, market access, pricing. The time you spent in Asia, I think that's also phenomenal because you really also have the best of both worlds, particularly now. You look at all the different ranging, regulatory changes and things like that. But let's start there. I mean, what's been your career milestone? What have been, I mean, I know milestone, it's not singular, but yeah, give us your life
Well, yeah, you're right. It's 30 years. I'm celebrating or commiserating 30 years in the industry this year. Started off my career with some of the larger agencies, which were fantastic grounding in healthcare market research. So started off with a company called Milpro, which later became NOP Healthcare, which now is part of GFK. Worked there for 3 years, where I met my current boss and mentor, Marianne Purdy, and we kind of worked together at various points throughout our careers, and it's great to be back together working. Um, then I moved on to TNS. Um, the wonderful TNS that became part of Kantar, that
I
became
think
part.
that's where we met. I think the TNS name. Yeah,
Exactly,
you're bringing back old
exactly.
memories for me now. TNS is when
Yeah,
we first met. That's right. Yes.
that's right. So I was brought to Asia by TNS to to establish TNS Healthcare as it was then, and that was when you were at McCann. I was there. We worked together, partnering on helping GSK to develop Avandia, for example, in diabetes. Worked across three or four different therapy areas with them, but also Abbott and other great companies that we worked with at that time.
Boy.
Um, so yeah, I was lucky enough with only 6 years experience to be asked to come to Asia to head up Asia. It was a great time
Wait, you
where
had
things,
6 years experience when I met you, and you were already like, for me, the guru of what you were doing. So that's amazing. Okay, all right. I didn't know that. Okay.
yeah, yeah,
Amazing.
I kept that quiet. The number of years experience, I tried to keep quiet. I grew a beard, so I looked
Your
older
beard.
and
I remember
more
your beard.
mature.
That's right. That's right.
But yeah, I was, I would say I was, they say in the kingdom of the blind, the one-eyed man is king. I was definitely the one-eyed man, I think, at that time.
Mm.
And but also, I think companies that we worked with loved our sort of can-do attitudes, our ideas, our ways of taking things forward.
Yeah.
And I think attitudinally we had the right idea at that time to really make a difference in Asia, where market research, healthcare advertising were all quite new disciplines.
Yeah.
And I think certainly I was in the right place at the right time to sort of take advantage of some of those opportunities that were presented to me.
Yeah.
Um, and the intention was only ever to come out to Asia for 2 or 3 years, and 15 years later, I returned back to the UK, um, having lived in Malaysia and Singapore, but obviously traveled around the region. We did a lot of work, didn't we, in Japan, in China, in Australia, in Korea, and all over the region, really. So got a really good experience of the region. And then as my career progressed, I also took responsibility for Middle East and Africa when I was at Kantar Health. So that broadened my perspective even further. And then, when you start to develop some emerging markets expertise, as they were called then, you also get involved in Latin America, in Africa, in sub-Saharan Africa, in many different countries. So it was a fantastic opportunity, even though I was based in Singapore for most of that time, to really get involved in some of those wonderful countries as well.
You've brought such a flashback, and for those maybe who might remember this or might find it surprising, we're talking about a time when the pharma model was so strategic, you could almost compare, at least for organizations that you mentioned, GSK always stands out. You could compare that to the kind of work that strategic level work at Unilever, or P&G for its time, Nike, because the kind of marketing and the kind of sort of integrated innovation was extraordinary. And
Mm,
when you were
mm,
looking at sort of creating a family of countries, almost a union for pre-launch and creating, I mean, just imagine, we used to have our best briefings with some of our clients, to be unnamed for world reasons, sitting in over a beer on a Friday. I mean, the insistence was we're going to get out of the office and spend the next 4 hours getting absolutely, you know, yeah, in another level, just so that we could come out with a better way to solve something for the Philippines, or come out with a better, perspective for HPV, and but those times just seem so far gone. I mean, it just seemed like it's such a long time ago. Yeah.
yeah, yeah. I,
You've
I, I'm not sure I ever had a briefing over a beer to that extent. Maybe that was McCann's way of working. Um, but uh, but definitely, I think one thing that still remains true to this extent, to this day, is the extent to which relationship plays a role over and above messaging or what you say. It's the bonds that you make with your agencies, but also with your doctors, with your stakeholders.
Mm.
And I've noticed this. The difference in an approach of sales reps, for example, in the Asia Pacific region, where there's so much focus on building strong relationships with doctors and a service type relationship.
Yeah.
Whereas in the West, I think the accent has been more on delivering the right messages, the messages that are going to motivate prescription or motivate certain actions.
Yeah.
I think that's a fundamental difference in the sales model for Asia versus the West.
Yeah, I mean, we used to have sales excellence and sales integration alongside marketing
Mm,
integration and marketing
mm,
excellence because you were always looking at how the respect for ultimately the patient, the responsibility of what it is that every word and every piece of evidence that you're going to share is going to make a difference. And it counseled, even to that extent, sales from a responsible, sort of medical education perspective, which I'm
mm,
sure has sort of, and we'll talk a bit about how, technology and AI has sort of just even left that, sort of taken that even further. I think the other part was it was such a multicultural sort of cross section as well. And
yeah.
it brought, I think, such a tremendous amount of different experiences, different ethnicities, context of religion, work that we did on Nestle, which was amazing, a room full of imams and Catholic nuns and researchers sitting together and saying, how do we understand certain factors? I mean, that level, you're right. I mean, the kind of things we did. Now, I promise not to dwell too much on the past because we have so much to cover, and I want to talk about the things that you're doing and how it may help sort of clarify things. But I'm going to sort of maybe embarrass you a little bit, but I remember this even when we used to work together. You've been into not just sports, but even fencing. And fencing, I think, is such a remarkable, I guess, aspect, right? I mean, you sort of have done, so please don't blush. I'm going to say things about the things you've done, the kind of things you've done across winning gold at the 1998 Commonwealth Games. I mean, reclaiming a title at the National Veterans Championships. Now, rather than dwelling on how great that is, just, I mean, for goodness sake, but what are the parallels between how sport got you into areas of healthcare decision making and I'm how has that sort of been part of your life and part of your professional outlook as well?
Um, yeah, I don't embarrass easily, Rohit, as you know, and I'm very shy about telling everyone about my achievements. So I'm glad you brought it up because otherwise I would have done it anyway. But um, in terms of the parallels, I think fencing is one of those interesting sports where it is a team sport, but ultimately when you're on the piste, it's just you against the other guy. There are a few sports like that. It's not like football, it's not like rugby, it's not like all of these team sports where you're very much reliant on your teammates when you're in the heat of battle. Um, but perhaps more like tennis, I guess. Team tennis, like Davis Cup tennis, where ultimately when you're on the court in tennis, you're also just up against the other guy, but you rely on the support of your teammates around you who are giving you advice. Um, so definitely a team sport, but definitely the onus is on you when it really comes down to it. And I think, we've all been involved in big presentations, big readouts of data, big strategic sessions that the onus was on you to stand up and deliver a piece of work. And I think those parallels are obvious. I think also when it comes to fencing, you get so many fights that go to 14 all, and it's basically that last hit. Who's going to win? Who's going to go through? Who's going to go out? And you have to have courage to decide what you're going to do and do it. And whatever the consequences, so be it. But the worst thing you can do is nothing. The worst thing you can do is wait for the other guy to make his move and you react to it. Because then the day will be lost. And I think that's also true for healthcare decision making. We all have to sort of fight our own fight. We all have to decide what is the right thing to do for our own situation and do it, almost regardless of what else is happening.
Wow. Yeah. I mean, it's not so much about the fighting spirit, but it's almost like, I mean, the way as you were talking, it's like it reminds me, once hearing about the sort of F1 racing where split moment decisions, it sometimes is a team sport, although not always, but you kind of know the risks to take, when to kind of push forward, when to kind of pull back. And as you were talking, it sort of reminds me
Mm.
that I think even as we talk about the factors to weigh, it couldn't get even more than when you're talking about research in healthcare, because sort of decision making or the protocols that have to be put, a lot of that can get subjective or qualitative, or sometimes, in the quantity side, you got to take calls because, I remember, a lot of these kind of, like where is it that certain insights are going to come from? Those insights sometimes aren't written on a piece of paper. It's not like it was there, but an insight just happens to have been said. So it's a bit like that, isn't it? Your sort of sports analogy of like knowing when to parry, when to sort of pull back, when to kind of say, go for it. I mean, I guess that's it's just synonymous with what you do.
Yeah, I think good researchers really bring their own opinions to the research. It's not just about what the respondent said, the doctors or the nurses or the patients, whoever the respondents are, but you have to add your layer of consultancy on top of it, your interpretation of the data, which aspects are important, which are not important, which things you should take with a pinch of salt versus which you should really base your strategy on. I remember when we worked together, Rohit, you and Graham Reed and the team had a lovely phrase, a killer insight,
Your
a
insight.
killer insight. And you used to talk about, I mean, we would come up with a number of different insights in market research, but we'd always be looking for the killer insight, the one thing that was going to enable our client to differentiate their brand or move their brand forward in some way.
Yeah.
Some sort of understanding of the human challenge, or really that was fundamental, that everyone got, but that you could build your brand strategy on. And I think as researchers, we owe it to our clients not just to report back what the respondents are saying, um, but to filter that and to make sure that they're hearing the killer insight
Yeah.
much more loudly than anything else.
Yeah. Oh boy. Yeah. I remember the five whys, the aha moment. So a killer insight was the aha moment. And then there used to be these little, we used to spend hours just simply saying, why is the refrigerator like an insight? Because the minute you open the door, the light turns on. And these little moments of inspiration before you even dived into a research presentation, so that everyone who's listening to that research presentation can ask the stupid questions, can ask the silly little trigger, and you don't just say, "Oh, that was the first insight." Insights have to be wide and out, all the way through.
Yeah.
That's so cool. I mean, you sort of, yeah. I mean, and so what do you think? I mean, in that case, as we talk about this changing face of healthcare market research, first of all, is there a changing face of? I mean, the way that you've just been talking right now, it's almost the evolution of research in market research. And we talk about this in healthcare or beyond. Insights is still valuable. The decision making factors has sort of expanded dramatically, but I guess how does that sort of look now? I mean, what are the biggest shifts in pharma healthcare businesses, or how does insight development, particularly when it comes to clinical research protocols and all of that? I mean, are you still finding the origin story still holds true? Is there something else that's happening? Well, what's changed?
I think that a lot has changed. I heard a wonderful phrase yesterday. We're living in the age of info-besity, um,
Fantastic.
which I haven't heard that before.
I'm
I don't
noting
know
it
whether it's
down.
going.
I'm noting that one
Are
down.
you writing that one down?
That's a good
We're,
one.
we're living in the age of info-besity because there is so much information, but the risk is that we overindulge on all this information, and we can't see the wood for the trees. And I think in this age of infobesity, the analyst is actually becoming the king, the person who can really filter through that information and find out the information that really makes a difference is incredibly valuable to organizations. whether they work in agencies or whether they work on the client side. Um, for me, working in healthcare, I think there are a few big changes. First of all, the therapy areas that we work in. Um, in the old days when I first started, we used to work in hypertension a lot. We worked in uh, acid reflux. We did a lot of work in that area. These sort of big brands, mass market brands that were successful. Then sort of towards the middle of my career, I would say oncology really came to the fore and did a lot of work in oncology. And then over the last probably 10 years or so, maybe certainly five, rare diseases has really developed as companies have seen that there are real benefits to developing drugs for rare diseases. They can achieve orphan drug status, they can get their drug to market more quickly, but also they can meet the needs, the incredible needs that patients have in these areas who don't have any treatment options available. And if you can bring something to those patients, you can really make a difference.
That's yeah.
So I think the therapy areas have shifted. Sorry.
I, yeah, and I was going to say that you brought up rare diseases, and I think that's really interesting you do that because in my past life at The Economist, I also realized what a shift into orphan rare disease investment was also happening.
Mm,
Uh, and when you try to look at the complexity of rare disease, it's probably the hardest one to do because there's never really a full mandate, even within organizations. There's always something there that people are going to push for, and it doesn't always end happily because
yeah.
sometimes if you're doing it in a preclinical phase or even if it's let's say in a marketing post-marketing kind of research, it's a tough one because it takes a family to raise the value of that particular rare disease, and so the integrity or the complexity then becomes really that you're at the intersection of traditional research and what you could say AI can do. AI can't solution find, but rare diseases forces you to bring the human into the mix. I don't know if that makes sense, but yeah, I mean, let's talk about rare diseases for a bit because that is actually something which is really becoming quite a thing. And where do you think right now, in terms of gaps, whether it's patient access, we know has always been that issue, treatment pathways has always been a factor, but are you seeing perhaps more clarity from technology inputs coming in here, or is rare disease still literally, we got to figure this one out?
It's very, very different to sort of mass market diseases, if I can use that term, because the patient, the caregiver are experts in rare diseases, very, especially with genetic conditions that they lived with lifelong. They've often taken years and years to get an accurate diagnosis and effective treatment. And so through that journey, they've really informed themselves. And often patients and caregivers are just as expert as the doctors they're talking to. Um, so you have this incredibly informed cohort of patients um, who who are very, very engaged. Um, but of course, from a market research standpoint, we can't achieve huge samples. We can't suddenly interview hundreds of people and get reliable data based on large samples. What we have to do is go deep to really make sure that for a small number of patients and caregivers, we're really understanding what their needs are. And then I think one of the most successful projects that I've been really proud of was we were working in rare kidney diseases for a particular client, and we sort of broke down the walls of the normal market research model. We conducted a focus group with patients and really understood their needs, but we had a group of key opinion leaders in the back room observing them and commenting. So we kind of ran two focus groups at the same time, one patients, and then also hearing what the key opinion leaders had to say about it. Once the patients were finished, did that for the first half of the day. We then brought the key opinion leaders in to sort of brainstorm what would be the most meaningful services beyond the pill that our client, the end client, could develop in this particular series of rare diseases. Um, and ultimately, the key opinion leaders and our client in the room together, noodling and brainstorming what particular services. We basically nailed the study right there and then in the room. We didn't have to write a report.
Wow.
We 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 were able to come up with two or three very meaningful actions that the key opinion leaders and company could work together to produce for the patients. And I think when you get that level of collaboration, and in rare diseases, again, it's quite unique because it is such an area of unmet need that key opinion leaders are very motivated to help. Companies are very motivated to help, and patients are very motivated to help. So you have this perfect storm of different stakeholders that you can bring together to drive solutions.
It's fabulous. I mean, staying on the same theme, I mean, one thing that we've also been sort of going through at the Voices Project is, we're working on a category for PAH, so pulmonary arterial hypertension, which is again fairly rare here, at least in Asia, because it, especially when it hits women in the last trimester and perhaps undiagnosed, it leads to some really, bad outcomes. And we tried doing something on an AI studio model, which I think, to your point about what you were going through, is that once you've got enough cases, which aren't so many, right? I mean, so you finished
Mm,
one,
mm,
as you just mentioned, storing that and building a training model that we have for PAH is almost to say that if there are predictive or simulations that can
mm,
actually, I'm not saying replace or rather, but rather augment and prepare for the actual face-to-face and the KOL sessions, then what we're experimenting out is, imagine if before we even start the whole kind of discussion, we've already gone through a simulation where the various levels of the AI model we're building is all the way from somebody with a really, really, sort of seriously late diagnosed PAH, already
mm,
hospitalized, still, expectant last time, versus somebody who's going through a much more, and everything in between, and then use some of those to sort of prepare and work through. And I'm wondering if in that way, AI and technology could play a role in these areas of rare diseases where, it's hard to find that evidence. And so if you have the
yeah.
evidence, it's almost like, how do you galvanize that?
So we've got some experience with synthetic respondents where in a rare disease, a rare cancer type actually, um, we saw how um, real respondents were combined with synthetic respondents to form more confidence around decision making. Um, and what we found is that synthetic respondents are very good at giving kind of the textbook patient response. Um, you ask a synthetic respondent, what are the risks of the immunotherapy that they're taking, for example. And the answer that you'll get from the synthetic respondent will be very textbook. You could almost Google it and, to find it out. Um, but what you will get from a real respondent are things coming from left field, things that you hadn't expected. I saw a lovely example at a conference recently, not the one I was at yesterday, but um, and again in oncology, they were asking real patients what the drawbacks of their chemotherapy were. And this lady said, what really upsets me is when I go and have chemotherapy, I can't play with my dog for a week
Right.
because of the risk of infection, because my immune system is um is compromised. So I can't play with my dog in case I pick something up off the dog, perhaps it's been rooting around in the garden and brings some sort of bacteria in. And that was what upset her. And you're never going to get that from a synthetic respondent. You're never going to get that level of human understanding. And going back to what we were saying about killer insights,
Mhm.
that's where the killer insights lie in market research. It's those types of aha moments that you hadn't realized. And I don't think you're going to get those from synthetic respondents. I think what you do get is validation. So if you can only interview two or three patients because it's such a rare disease, that's fine.
Mhm.
Use synthetic respondents to sort of validate some of the sort of nuts and bolts of the research, what you're hearing, make sure it's true. But make sure you don't miss those aha moments as well that are coming through from those two or three patients.
I mean, again, you always remind me of those moments. I think the one that always sticks with me was, I think it was for pet food. And it was the usual kind of like, I think it was for Purina, I think. So it was again for Nestle. And it was, things about, oh, I want to give my pet the best thing. Yeah, sure. I want to make it, free from antibiotics, hormones. Yep, yep. I want to, and it goes a little deeper. And then finally, there's someone who has a breakdown moment emotionally, takes out a photo of their pet and says, it's because for me, this is my child. It's a human. And therefore,
Mm,
I would give it human-like food. And then you
mm,
realize why, it looks like steak and kidney pie. And people
mm.
are like giving that to a dog. But no, it's because of the insight that drives it. And it's the same true. You're absolutely right when it comes to sentiments and feelings and emotions. And, I think hopefully we'll see at some point when there's enough training here that voice processing can even help understand certain analytical responses. So, for instance, the next time you're actually holding these groups or one-to-ones, you may also have the AI listening in and just simply measuring and capturing and doing things because at some point maybe it'll just give a little bit of an outcome. But let's talk about the AI bit. But so not staying just in the rare disease field. I think today's world is so polarized. You look at COVID and you think about vaccine diplomacy, all the various ways that different governments and expenditures are now being shaped and reshaped. But when you think about patient access, treatment pathways, and things like that, I mean, where do you think the situation, let me just ask in a nutshell, do you think it's going to get harder for funding? Do you think that now it's going to become more difficult for trial selections? Is that sort of like the unfortunate sort of reality at this moment in time?
Um, I don't think we can answer that question in a blanket way for every country. I think it's going to be different depending on the attitude and the level of development of the healthcare systems in each country. If you take a country like Vietnam, for example, where you have a growing middle class, you have more investment in the national healthcare system than used to be. You're going to find that basic treatments are covered in a slightly better way than they were in the past. In contrast to where I live now in the UK, the NHS now is just bursting at the seams because it was never created to cover all of the incredible therapies that we now have. When it was created just after the Second World War, it was to give people basic health care. And now if you just take oncology as an example, the incredible treatments and developments in oncology and what the NHS is being asked to cover, it was never actually created to do that. So what you end up what ends up happening is that you get inequities in healthcare, you get postcode prescribing, you get certain drugs being covered in certain areas of the country, and people are incredibly dissatisfied because not everything can be covered. So I think it's very difficult to answer that question in a blanket way. I think, we have to look at it country by country, and we have to look at what their healthcare systems were set up to cover and make sure that they're covering, you know, what is essential.
Yeah.
Again, if I take my own situation over the last 6 months, um, I've cost the NHS a lot of money. I've had brain surgery. I've had three flow diverters placed in my brain. I've had 18 coils. Apparently, the platinum in my head cost more than £50,000 just the medical devices, let alone all of the surgical expertise, all of the diagnostic tests, everything else that I've had. Um, And the NHS is brilliant at that, at providing that acute, life-threatening type of care. Um, but should it be asked to cover every single lifestyle type of disease, or everything that we want to improve our quality of life? I don't think it can. I don't think it can cover everything.
Yeah, gosh, yeah. I mean, it's interesting you say that story. I have a relative who lives in Switzerland, and he's about, I would say, in his mid 70s. And he began to sort of obviously show signs of, again, I'm not going to be able to medically accurately say this, but sort of like Parkinson's, but a bit of a stroke nature too. And he
Mm.
was losing motor movement. And I mean, I know that if this was somewhere in Asia, it would have been probably just considered palliative care or just basic symptomatic care and all that. And I visited him again, I think maybe 6 months later, and my aunt told me, oh, he's gone for a special treatment. And the way she described it was like, they're going to put implants in his head, and it's going to be basically like a pacemaker for the brain. That,
Oh,
and
I
it's
think you're talking about DBS, deep brain stimulation.
So you know this, but it's like it's embedded. So the actual battery is inside him. And
Mm,
when I saw him, I couldn't believe it. I mean, he was obviously age-wise the same, but he
mm,
was 20, I'm not kidding, 15 years younger.
mm,
And he was joking. He said, if I turn the dial a bit, I sometimes start remembering and really get very very juiced up in terms of my nature of conversation, and he was remembering things that even forget about it. Yeah, I wouldn't have remembered about things that happened and whatnot. And I just found that like impossible. So your point that the US, Europe is always standard bearers for innovation and
yeah,
having sort of the grace to say, let's sort of cascade that and send that out to the world.
mm,
Um, I think that is kind of like for Asia now, a real moment, because I think for too long, Asia is sure sort of been at the center of a lot of innovation, but it's never really had the ability to produce it at scale. And even in
yeah.
Asia, there's obviously the haves and the have-nots, right, within the countries and so on. So it's yeah, no, I mean it's I guess, do you have any comments on the Asia perspective? I know you've been out of here for a while, but do you see like kind of what does the horizon look like? It's going to be rough going for this kind of stuff, or what do you think?
I think you're right. It's very challenging for anything to happen at scale, in Asia. And even outside of the US, when I look at, we were just talking about DBS, deep brain stimulation. Um, that has come on. It's actually been around, that technology, for at least 20 years. It's not
Really?
new,
Oh my gosh,
but
right.
it hasn't really gained a foothold to the extent that we would like to see it. We work particularly with Medtronic on this, and there are three companies really who are driving technology in DBS. Um, and it's now having indications not just in Parkinson's, essential tremor, dystonia, but it's progressing into epilepsy,
Oh,
and beyond.
right.
So it's incredible technology, but it is very expensive.
Yeah.
And at the end of the day, it's also brain surgery. If
Mhm.
you're a Parkinson's patient and you're offered brain surgery, that's a scary proposition. That's you have to open up your head and put this thing in,
Yeah.
and that is a scary proposition. Um, but for those who are brave enough to go through that, the rewards are incredible. And the programming capabilities are incredible. And I,
Yeah.
I think what it takes is then key opinion leaders in each country to establish a center of excellence and take this type of technology forwards. What I haven't seen yet, outside of what I would call developed Asia. So when you look at Japan, for example, a lot of innovation coming from Japan, a lot of innovation coming from China, as well, um, Australia as well, of course, and Korea in certain therapeutic categories. Outside of those countries, I'm not seeing a huge amount of innovation. Instead, it's more focusing on technology that exists and how can we make it cheaper? How can we produce it in a more accessible way? And that seems to have been the focus a little more.
Yeah,
Um,
true.
you've been talking about AI though. I think that really could be an area
Mhm.
where in Asia we really take the lead.
Yeah.
I think the opportunities that AI presents in terms of diagnosis, running diagnostic patterns, imaging, being able to identify cancers or diseases through imaging that the human eye may miss,
Mhm.
or identifying those earlier than the human eye can catch.
Yeah.
Um, I think there are huge opportunities there for Asia to take the lead.
Yeah. I mean, everyone always looks at it and says, there's hope still, but yeah, I think that'll probably be for our. I think I have to have you back again because I mean, that in itself is a whole opening up of a hornet's nest of all sorts of conversations. Now, what I'm going to do in about the 10-15 minutes we have is I'm not going to do a rapid fire, but I'm going to just basically, I want to try and capture as many of like the key questions that I know many of our listeners are always keen hearing these conversations from experts such as yourself. And so, in no particular order. So, for those researchers out there, I'm sure they're asking, so what would you consider an outdated research practice, if you don't want to name any, but what do you think is going to be replaced? Or where do you think things are going to now? People just, young folks coming in, investing a lot of time and energy. What would be your advice?
Outdated research practices. Well, I'm going to be shocked by some of my colleagues, but I think focus group discussions are very outdated. Um, we very rarely get doctors or respondents together in a room together. Um, a lot of it can be done through online communities that we much more often run, and the benefits of online communities are that because they run over a period of time, normally a couple of weeks, you can actually adjust your discussion guide, your questioning based on what's come up at the beginning of the online community. And that's not the case with focus group discussions. With focus groups, you normally have your guide. It sort of lasts about 2 hours. Your ability as a moderator to go outside of that guide is somewhat limited because you don't know the client's business as well as they know it. Um, we're finding that online communities are a lot more flexible, and of course, the real benefit is you're not asking people to come into a hotel or into a central viewing facility. They can log on whenever they want. They can log on the bus, on the way to work, in a taxi. They can do it whenever they like, and it's so convenient, and it's so how people are used to interacting nowadays.
Yeah, the listening techniques. Um, so this could be a yes or no answer because we could talk about this for 30 minutes, I'm sure. But is AI now getting overhyped in the field of market research? Is it complementary? Is it what would you say?
I can't stand these conferences that only talk about AI, Rohit. There's
Right.
so much innovation out there that's over and above AI, but it's definitely offering a lot. It's things like sentiment analysis. We use a tool called Phoebe AI, which just adds a layer of analysis over the top of um, what our more rational analysis is doing. At scale, that's very valuable. In qualitative research, I think a good moderator will pick up most of that stuff. But if you're looking at big samples, you can analyze audio or video entries in quantitative surveys through that, and it's really valuable. So I think AI can just add that maybe 5 or 10% on top, which is useful. Where I think it's also helping is to speed up the market research process. So we use an AI tool to help with our coding on quantitative studies. Gets the coding about 80% there. We then overlay some human checks and human coding on top, but it saves a lot. It saves a lot of time, and it actually improves quality. It's not just about time savings or cost savings. We found there are certain codes that the AI tool picks up that our researchers miss because they're human. So by blending AI tools with human intelligence, I think you'll get better quality, you'll get faster, and maybe a little bit cheaper as well.
So Stephen Potts is walking around in his hotel conference and suddenly says, "Hey, I just bumped into a big time pharma CEO. And what if you had that 5 minutes?" And the CEO said, "Hey, Stephen Potts, what's up with you? What's the one thing that you'd push in terms of market research innovation?"
Oh, this is a personal bugbear of mine, and it's making sure that we're including multiple stakeholders in market research. Um, the patient is still not at the center of what we're doing. Lots of companies talk about being patient-centric. I've seen very few who truly are patient-centric in how they're developing insights, how they're developing brands, how they're running their business. Certainly when I was in hospital, it gave me a renewed sense of how important other people are beyond the doctor. My experience in hospital was hugely affected, positively and negatively, by brilliant or less than brilliant nurses, brilliant therapists or less than brilliant therapists. Luckily, I had overwhelmingly brilliant nurses and brilliant therapists. But I have no doubt that my outcomes were affected by all types of stakeholders, not just doctors. And I think as an industry, we over focus on doctors still. We under focus on patients. We under focus on allied professionals such as nurses and therapists. And if I had 5 minutes with a pharma CEO, I'd say, please, please, please make sure you're building your business not just on what doctors needs, but what patients and allied professionals also need.
So for those out there saying, "I want to get into market research," and boy, does healthcare market research look exciting, what skills would be the most valuable that comes right off the top of your head?
Um, I think being inquisitive is the most important. You mentioned it earlier in our conversation, Rohit. You said you ask why again to get to that fundamental truth. If you're the type of person who hears a response and you just take it at face value, you don't dive into it, you just accept it, you move on. Market research may not be for you. Um, but if you're the type of person who has this inquiring mind. You want to get beneath the surface of things. You really want to understand why things are the way they are, and keep asking questions until you're satisfied. That I think's the number one skill in market research. It's interesting because we get lots of CVs through the door, of course, and the one thing we don't filter on is what degree people have done. We don't care what degree they've done because um, very, very often it's more about the attitude and the inquiring mind that we're looking for. So we want people to have the right values, the right approach, but what subject they've studied actually doesn't make much difference.
So if this was maybe a few years ago, I would say, "Hey, Stephen, what book are you reading?" and stuff like that. But if you were to talk about, let's maybe turn it around a bit. What sort of influence or resource or mentors come to mind as you look back on your career? Uh, what now, what in the past, if you could just say, "Yep, those things really made an impact on me," and today I would recommend a book or a source, and we'll note that down and it'll be in the link down below. So everyone, you can sort of have a look at that later. But yeah, Steve.
Well, I'm looking at my bookshelf now I'm not a big reader, I have to admit.
Okay.
Um, these days I blame it on the eyesight problems I've had since my brain aneurysm, but actually I was never a great reader. I have the attention span of a goldfish. Um so so I'm not sure I can recommend any titles. My big influences have actually been mentors throughout my career. I mentioned uh uh, Marianne Purdy, who I started off my career with as a fresh graduate. She was a director at Millpro, later became NOP Healthcare. and I'm now back working for Purdy Pascoe, and she's the Purdy of Purdy Pascoe. So it's lovely to be back working with her. Lynette Cook, who was my CEO at, at Kantar Health, had a huge impact on my career. Lovely person to work with, a great business lady, but also a great mentor. And so I think she had a big impact. We also talked about TNS days. So I was lucky enough to be responsible for driving healthcare, but within a much broader um, sort of group of leaders there. And one of the people who set up TNS was a guy called Tony Cowling, who unfortunately died a few years ago. But the way he grew a business, he knew everyone. He knew the receptionist. He knew everyone in the business, and took a personal interest in them. And John Smurthwaite, who headed up TNS for in Asia, I think had a very, very similar approach. And those have both had huge influences on me as a leader, on the type of leader that I want to be. Um, so it's more people. Sorry, I know that's not very helpful,
Oh, no,
Rohit. Not
these are
not
names
that people
that,
can look things
no,
up, but
I mean, I think it's all about legacy at the end of the day. The fact that these people, with us or not, can at least know the impact they made in people's lives. And I can speak firsthand. I remember coming to the TNS office, and I used to always say it's the kindest, generous, most generous people in that office. Just everybody from top to bottom was like in the DNA. And I'd go to other places or research company, and then the usual kind of like, the politics of that and whatnot. And I used to say there's something unique. And it's important you say these names because we're gonna mention down the links, and these people deserve the kudos. Um, I guess in terms of your career, your entire takeaways, we've talked about, I think, so much. I mean, I always try and limit this each episode to an hour, which is why it's hard to sometimes expand. But, we've had folks come back, and I mean, I think people want to learn about your sports, how fencing made a difference. Maybe just talk 30 minutes about fencing, and we can pick up analogies out of it. Personal resilience, everything that you've sort of looked at and done. But tell our listeners, how can they stay connected with you? Or you can sort of just give a reference, and we'll pin that at the bottom as well.
yeah, probably my LinkedIn profile is the easiest. So I'm very active on LinkedIn. I try to share useful pieces of information, articles. So if you look for Stephen Potts at Purdy Pascoe on LinkedIn, that's probably the easiest way.
We'll have that link down below. So when this is put up there in our RSS feed, you'll see it. We're also going to probably start doing this more as video podcasts. So it'll be up on YouTube channels as well. So we'll have that done. Look, always as a call to action at the end of the day, what these conversations are is just encouraging us all to connect, reconnect. In the case of Steve and I, find the opportunities, whether distance or not, you happen to be in town, make that call, catch up for the coffee, sit down, share thoughts, connect on LinkedIn, connect with Steve Potts. I'll tell you, I mean, you'll have a remarkable, remarkable connection there, and continue the interrogation, continue the conversation wherever it takes you. And hopefully this has been a great first episode. And I think the next one, I won't give anything on, but it's an interesting teaser on what we're hearing about South Africa and the politics going on there. So I think I'm looking forward to that one as well. But appreciate the listeners listening in. Appreciate you, Steve, for everything that you do and for joining this as well. So glad to have had you.
Thank you, Rohit. It's been an absolute pleasure, and I'll happily come back anytime you would like me to talk about myself a bit more.
Wonderful. Thank you so much, Steve. Thank you.